Good morning, good afternoon. I'm Monica Pica with Sachs Healthcare, and I will be your technical producer for today's webinar. Firstly, on behalf of Philips and Sachs Communications, we want to thank all the frontline workers in our audience for your commitment and passion in helping all of us through this very difficult time. We are truly indebted to all of you. Before we get started, I'd like to review a few housekeeping details. Today's webinar is being recorded, and an online archive of today's event will be available soon after the session. You may ask a question at any time during the presentation by typing your question into the Q&A box on the right side of your screen and pressing Enter. Our speaker will answer as many questions at the end of the presentation as time permits. If you experience technical difficulties, please use the Tech Support tab, also located on the right-hand side of your screen. If you have trouble seeing the slides at any time during the presentation, make sure you are not behind a firewall. Please use the Chrome browser, and if you continue to have issues, please press F5 to refresh your screen if you're using a PC, or Command R if you're using a Mac. The handouts for this event can be downloaded from the Handouts link located at the bottom of your screen. Our moderator today is Kathleen Volman. Kathleen is a critical care clinical nurse specialist, educator, and consultant. She has published and lectured nationally and internationally on a variety of pulmonary, critical care, prevention of healthcare acquired injuries, work culture, and sepsis recognition and management. She is a subject matter expert for prevention of COTI, CLABSI, and HABI, as well as sepsis recognition management and the culture of safety for HRET and the Michigan Hospital Association. Ms. Volman was appointed to serve as an honorary ambassador to the World Federation of Critical Care Nurses. Welcome, Kathleen.
Thank you so much, Monica, for that very kind introduction. Good morning or good afternoon to all of you. The title of today's webinar is COVID-19 Clinical Deterioration Outside the ICU, Prediction, Detection, and Escalation. Speaking today on this very timely topic is Steve Dixon. Steve Dixon is currently the National Clinical Consultant for General Care for Philips. He has been working with Philips in a clinical capacity for over 10 years, and in that time he provided his clinical expertise for a range of clinical settings and technologies. Prior to joining Philips, Steve was the Clinical Practice and Education Specialist, Respiratory Care Transport Team at Children's Hospital of the King's Daughter in Norfolk, Virginia. While working in a clinical capacity at several hospitals, he has pursued his interest in education as a respiratory care educator at various hospitals and academic institutions. He has published several articles in peer-reviewed journals and has been an invited speaker at numerous local, regional, and national professional conferences. Our speaker has the following disclosures. He is an employee of Philips. So this educational activity is approved for 1 contact hour for nurses and respiratory therapists. A link to obtain your certificate of completion will be available at the conclusion of the webinar, and you have your accreditation statements there. Support for this educational activity is provided by Philips. And at this time, I would like to turn the presentation over to our speaker, Steve Dixon.
Thank you so much, Kathleen, for that introduction, and thank you, everyone, for joining. Before we begin the presentation today, I want to take a moment to express my appreciation for the dedication and sacrifice and commitment to delivering exceptional care during these extraordinary times. And thank you for all that you do to make a difference in the lives of patients and families every day. I want to begin by reviewing the learning objectives for today's presentation. We are going to discuss the leading predictors of clinical deterioration in non-COVID positive patients as well as COVID-19 positive populations. We're going to discuss key clinical complications of COVID-19 associated with rapid clinical deterioration, and we're going to discuss the role of early warning scoring and predictive algorithms in guiding the escalation of care for COVID-19 patients. COVID-19 has had a profound impact, as we know, on the United States and really the entire world. And life, as we have known it, has been changed dramatically. And the clinical and operational impacts of COVID-19 on hospitals continues to be felt as the surge of COVID-19 patients begins to impact hospitals across the U.S. and around the world. As of Sunday, there have been more than 9.28 million recorded cases of COVID-19 here in the U.S. More than 551,000 new cases have been recorded since January 21st. And since the onset of this pandemic here in the United States earlier this year, there have been more than 231,000 deaths recorded. The ICU admission rate varies between clinical sites and ranges from 4.9 to 11.5%. Mild illness is reported to be about 81% of cases. Severe illness is seen in about 14% of cases, and critical illness is seen in 5% of those cases. Before we begin talking in depth about COVID-19, I want to take a moment and review some research that was done looking at the strongest predictors of clinical deterioration and use that as a reference point, because some of what we know through experience, some of what we know through daily practice has a bit of a contrast in what we see clinically with patients presenting with COVID-19. This graph is work that was done at the University of Chicago, and it was a 5-year study that enrolled 269,999 patients, and these admissions occurred to the general care space at 5 metropolitan Chicago hospitals. And through this research, they've followed each of these admissions through their hospital stay up to and including death. Of those patients that were enrolled in the study, 16,452 patients experienced an adverse outcome. 13,188 of those patients required transfer to the ICU from general care. And of those patients that were transferred, there were actually 2,840 deaths, and then 424 cardiac arrests and resuscitations. So as you can see, this research looked at the population that was enrolled all the way through the stabilization of an adverse event that may have occurred in a general care space, or up to and including transfer to the ICU. What we notice is that respiratory rate, through their findings, manifested itself with an abnormality in 100% of the deterioration events. Heart rate was found to be present in the form of abnormalities in 77% of those cases. And interestingly, age actually came in as the third strongest predictor of clinical deterioration. And so as we think about surveillance today in the general care space, the areas outside of the ICU, respiratory rate and heart rate are the two leading indicators. Another interesting observation that they found through their research was that SpO2 did not actually make the top 10 in their research findings. It actually comes in at number 11. And the reason for that is that in most deteriorations, SpO2 is a late indicator of deterioration. And so as we give thought to where we are today with the COVID-19 population, how we're looking at patients, the surveillance that we're employing, the technology that we're employing, we're going to discover some of the nuances of the COVID-19 population in comparison to what we have seen prior to the onset of COVID-19. As I mentioned, respiratory rate is the leading indicator, and we'll talk in more detail in just a few moments about respiratory rate as it relates to COVID. One of the challenges that we face every day with a respiratory rate outside the ICU is that it is the earliest predictor, but it's also the least accurately measured of all vital signs. And if we go back in the literature, we can go back to 1993 and actually find the first article in a peer-reviewed journal that actually pointed to the role of respiratory rate as an indicator of impending cardiopulmonary arrest. Additional work was done about 5 years ago looking at the comparison of both the respiratory rate and heart rate that were documented. And this was in the form of a study that involved the chief resident at 5 different medical centers actually going in and doing their own assessment of both respiratory rate and heart rate before a nurse tech went in to do the same measurements. And what we found was that while there was excellent correlation between heart rate between the chief resident and the nurse tech, there was very poor correlation between respiratory rate measured by the chief resident versus the nurse tech. That data was also validated in additional work done at the University of Chicago. You can see the bar graphs on the top right. We actually were able to deploy an automated sensor that wirelessly measured respiratory rate, and then we're able to compare those measurements to the documented respiratory rates that were found ultimately in the chart. And as you can see, the top there on the right, as we find in many hospitals, patients are commonly charted as having a respiratory rate of 16 or 18 or 20 breaths per minute. The bar graph distribution just below that shows the actual true measured distribution of respiratory rate. And then most recently, there was an excellent article published in the Joint Commission Journal for Patient Safety and Quality, and it really did us an excellent job of level setting where we are today with the respiratory rate, the role and the importance of respiratory rate. And if you haven't had an opportunity to read that article, I would really encourage you to be able to take the opportunity to do that. So I mentioned the research that was done at the University of Chicago. There was an output from their research that I think is extremely important. Again, as we talk about COVID-19, we look at surveillance in the general care space. What they actually noticed was a direct relationship between the risk of a serious adverse event, that's the vertical axis, versus respiratory rate along the horizontal axis. And what you'll notice is that as we get to a respiratory rate of 20 breaths a minute, we start to see a return back to that baseline of risk. But as we transition from a respiratory rate of 20 up to about 24 breaths a minute, we see a very sharp, a very dramatic rise in the risk of a serious adverse event. And what this research has demonstrated very nicely is that as a respiratory rate exceeds 24 breaths a minute, the probability of a serious adverse event increases dramatically. And so as we look at patients, especially those that are not monitored continuously, we can't emphasize enough the importance of ensuring that accuracy and respiratory rate, and that those patients that are starting to show an increase above 20 breaths a minute, that there's visibility, there's awareness among the nursing staff, so that timely escalation can occur typically through an increased frequency of assessment or the addition of more continuous forms of patient monitoring. Now, as we transition into the COVID-19 population, this is a summary that I put together. This article was actually published back in February of 2020. The data from this actually was generated from Wuhan, China, shortly after the recognition and the realization that they were seeing a disease that had not been previously appreciated. And what I want to highlight is that if we look at several elements in this, it's interesting, and it's actually very foretelling of where we are today. And it's interesting that they noted some of these findings. So I want to begin with dyspnea. So if we think about dyspnea, we recognize that by definition, it's actually labored or difficulty breathing. And what's really important to note is that for the patients that did not require ICU transfer, 37% of those patients actually had a complaint of dyspnea. If we think about that in another way, there were patients that were, as you can see, 92% of the patients that were transferred to the ICU actually complained of dyspnea. But what about those patients that are not transferred, that are on the general care space, that are COVID positive? So the onset of dyspnea certainly needs to be evaluated. And as we combine that finding with other physical findings and patient complaints, then we have a better appreciation for the potential and the likelihood needing to move that patient. I want to drop down to the fourth row where we have a respiratory rate greater than 24 breaths a minute. What's really interesting, we talked about in the non-COVID population as respiratory rate being the leading indicator of deterioration. It's interesting that only 62% of the patients that required transfer to the ICU were documented as having a respiratory rate greater than 24 breaths a minute. If we look at the no ICU transfer, only 14% of the patients were documented as having a respiratory rate greater than 24 breaths a minute. And so the message here is that we can use, and we need to be looking at respiratory rate, we need to be following the patient complaint, but we're going to have to do more in the form of monitoring, and we're going to talk about that here in just a moment. And as you can see down here at the very bottom, the World Health Organization's recommendations are that for a respiratory rate greater than 30 breaths a minute or an SpO2 of less than 93% on room air, those patients need to be immediately moved to ICU for their evaluation and medical management intervention. Now, the progression for COVID-19 as an illness has a fairly standard path that it follows. Suffice it to say, though, not every patient's going to follow this timeline. And so it's really important that we recognize that while the average onset of dyspnea in this population for Wuhan was on the 8th day after the onset of symptoms, there were patients that actually presented that had an earlier onset. And likewise, while there was a 10.5 day median time from the onset of initial symptoms until the patient actually showed evidence of an ARDS-like clinical picture requiring intubation, mechanical ventilation, there were patients in this population that presented as early as 2 days after the onset of symptoms, and in fact, on day 2 required emergent intubation and mechanical ventilation. So the timeline serves as a reference, but we recognize that not all patients follow all of the anticipated paths. So the ultimate goal then is to be able to blend the power of an accurate predictive algorithm with monitoring technology that's available in the right setting based upon the likelihood of deterioration. Now, some of you on the call may have heard the term happy hypoxemia or happy hypoxia. There have actually been news stories, TV spots with interviews generally of emergency department physicians who describe these patients that are COVID positive who present, who actually appear to be in minimal, if in fact no distress at all, but when a pulse oximeter sensor is applied, the recognition then is that the patient actually has an SpO2. In some cases, anecdotally anyway, been reported in the high 70s, low 80s. I think there have been a couple of isolated cases reported even lower than that. But What's really important to recognize, though, is that when we have these patients who present, especially those that have the underlying hypoxemic processes that are underway, they're already experiencing significant physiologic change associated with COVID-19. And there's some variables that actually play into this. The first one is that the body's ability to regulate pulmonary blood flow is compromised. So we don't see the management of pulmonary blood flow as we would in a patient that does not have COVID-19. And what that translates to then is the ability to see an increase in intrapulmonary shunting. With the inflammatory processes, we can see leaky capillaries that leads to the movement of intravascular fluid into the alveolar space, resulting in the inactivation of surfactant. And then with the loss of surfactant, we see de-recruitment, the formation of atelectasis, and then an additive shunting that results from consolidation of alveolar units. And as this process continues, we've got good documentation now, good evidence of the intravascular microthrombi that actually form as a part of these processes. And those fibrin deposits then can actually further aggravate and exacerbate worsening oxygenation, making it even more difficult to not only oxygenate, but ultimately when these patients are ventilated, we can find significant intrapulmonary volume loss. Ultimately, we see a reduced lung compliance, we see an increase in dead space, consolidation, and atelectasis, and ultimately, as probably many of you have seen, we find these patients failing oxygen therapy, whether it's low-flow support or high-flow nasal cannula, and ultimately needing to be emergently intubated. So, as we think about the hypoxemic patient and we think back to the original top 10 indicators or predictors of deterioration, the role of oximetry in the surveillance of COVID-19 patients is extremely important. And there's been some discussion about the role and relationship between respiratory rate being an important factor versus an oximeter. And the reality is that we need to be surveilling both of those parameters. They both are important, but it's important, really, really important to understand that without an oximeter, it's extremely difficult to appreciate how far the progression of COVID-19 has gone and at what point the patient needs to be emergently transferred to a higher level of care. There's been some work done looking at phenotypes, and I'm not going to belabor this particular portion of the presentation. Suffice it to say that there are variations from a hypothesis standpoint, and given the fact that this is a hypothesis, I'm not going to spend a tremendous amount of time on it, but I did want to make you aware that there is information in the literature, and Gattinoni and his colleagues did a really, really good job putting this information together. But for today's presentation, I think we'll move on over and talk about the complement-associated microvascular injury. And because this really has not only a profound impact on pulmonary vasculature, but we also recognize now that it has a dramatic impact on renal perfusion, cerebral perfusion, coronary perfusion. And this article was actually done extremely well, and I really, really encourage you to take some time and review it. So let's begin our focus now on surveillance and some of the algorithms that are out there today and available. The MEWS algorithm is actually a scoring system that was initially created by the Royal College of Physicians in the United Kingdom. The predecessor to the MEWS algorithm was the MEWS algorithm. And there was a lot of focus and attention on the standardization of patients. And the ultimate goal was to create a format by which a physician at one hospital could speak to another physician, and by making reference to a news score, there would be an appreciation for the level of deterioration or the level of stability that a patient had. So if they were doing remote consults or if a patient needed to be transferred, then there was an appreciation for the status of the patient at that time. News scoring or modified early warning scoring, pediatric early warning scoring, there are a number of algorithms that are in use around the world today. But the primary difference now between news and news 2 really focuses on a few factors. First and foremost, the news 2 algorithm actually creates 2 categories for SpO2 targets. And you'll notice there on the third line and the second and third line, you see that there are categories based upon the target SpO2. When the news algorithm was initially released, we would be providing clinical care for a patient that had a baseline SpO2 of 88%. Those scores then were skewed because a patient, though they may be at their baseline, automatically had an early warning score of 3. So the decision was made to add a different targeted line so that we could be scoring patients based upon their baseline to get a more accurate assessment for trending and correlation purposes. There was also a change made in the use of confusion, new onset confusion. As we know, patients that are starting to show evidence of deterioration oftentimes will have a manifestation of confusion. And so rather than relying on the AVPU or alert responsive to verbal, painful, or unresponsive assessment, new onset confusion has been added to the NEWS2 score in order to be able to identify one of the other perhaps underappreciated clinical indicators of deterioration. And then the last change that occurred in the NEWS2 algorithm was a change in the colors or the risk bands that we use to identify deterioration. Some sites, rather than focusing on numbers, actually refer to the colors associated with each of those scorings. And for patients that are being cared for by someone that has color blindness, red and green color blindness, the original scoring algorithm, because those colors were used, put those clinicians at a bit of a disadvantage. And so the colors have been changed to eliminate the problems associated with colors that were in use. So there was research that was done. This actually was in the form, in the form of a letter to the editor in the journal Resuscitation. And what's interesting in this article is that, you recall, and again in the earlier slide where we were looking at the top 10 risk factors, age was reported to be the third leading predictor of deterioration, with respiratory rate and heart rate being number 1 and number 2, respectively. In this study, which looked at NEWS2 versus NEWS2 plus age, they looked at a population of about 200 patients, and these patients were studied and found to have a median age of 62.13 years. So they were a little bit over the age of 60, and a comparison of the accuracy of NEWS2 versus NEWS2 plus age was made. And the algorithm, with the addition of age, actually included a score of 3 for patients who had an age over 65 years. And no other changes were made in the algorithm, only the addition of age. Differences in the sensitivity and the specificity of each algorithm were not statistically significant. And the consensus of this study was that trending scores provides the means for accurate identification, and that in order to improve the patient's prognosis and ease the surveillance demands on medical staff, using an automated score or a NEWS2 score provided some benefit. For this specific study, age did not significantly influence or impact the accuracy of deterioration compared to NEWS2, And we recognize that there has been a tremendous amount of attention. There's been a lot of media focus on the correlation between age and adverse outcomes and mortality and morbidity with the COVID-19 population. But in this particular study, with the score being set at an age of 65, it did not yield any clinically significant difference, as reflected by the receiver operator curve in the graph on the right-hand side. Another study that is really of interest is looking at the comparison of the components of scoring systems. The NEWS algorithm, the NEWS2 algorithm, focus on vital sign measurement and assessment. And one of the questions that's come up is, what is the relationship, what is the comparison between SIRS, QSOFA, and the National Early Warning Score, and what are the differences and what are the impacts? And if we look at these, the comparative data, what we find is that in this particular study, it was a retrospective observational study of 110 COVID-19 positive patients, and they did a comparison of the accuracy of SIRS, or the Systemic Inflammatory Response Syndrome, QSOFA, which is the Quick Sequential Organ Failure Assessment, and NEWS in predicting clinical deterioration. And they undertook this research by scoring the patients at the time of admission. So in this study, they actually found that the National Early Warning Score demonstrated equal or superior accuracy compared to SIRS and QSOFA for predicting clinical deterioration. When they dug a little bit deeper, they actually found that SIRS and QSOFA actually were more predictive of clinical outcomes for patients that had lower risks. So there was poor correlation with both SIRS and QSOFA. In the earlier discussion, we talked about silent hypoxemia, and we learned that COVID-19 manifests itself sometimes with a normal respiratory rate, but low SpO2 measurements. And so if we look at the content of NEWS compared to SIRS and QSOFA, we recognize that NEWS predictions were highly accurate in predicting COVID-19 clinical outcomes because respiratory rate, SpO2, and the use of supplemental oxygen delivery are integrated into the scoring algorithm. Now, it is important to note this study has some limitations. It was a small study. It was a retrospective study. And as with most of the research that's available today with respect to COVID-19 and COVID-19 surveillance, the sample sizes do continue to be very small, and we need to be cognizant of that. Another research project looked at the variability of NEWS2 versus the score on admission. And it was interesting to note that NEWS was actually intended to be not only an assessment done initially, but typically done every time vital signs are obtained on a patient. And in those patients that show evidence of clinical deterioration, we increase the frequency of vital sign measurement and simultaneously then have access to more frequent trending of the National Early Warning Score. So this particular research study focused on the variability that was seen in the course of following these patients during their hospital stay. What was identified was that while the initial NEWS score, the NEWS2 score, did not predict mortality, 40% of the patients who died presented with a NEWS score of somewhere between 0 and 3. 43% of the patients who survived had a NEWS2 score of 5 or greater. So there was no significant difference in the admission NEWS2 score and its components between the patients who died and those who survived, except for systolic blood pressure. What's really important is that the patients who died had higher variability in their scores compared to those who survived. 70% of the patients who died during this study had a maximum daily change in their National Early Warning Score 2 score of over 5. None of the survivors displayed this degree of variability. So it's the magnitude of variability in this study that reflected the highest probability of death. So we've focused on the use of the National Early Warning Score. I want to transition a bit to some algorithms that initially were designed to evaluate the severity and the risk of community-acquired pneumonia. And in this particular study, what we see is a comparison of the ADROP, the CURB 65, PSI, the Pneumonia Severity Index, SmartCop News2, CRB 65, and QSOFA. And the goal was to be able to appreciate the differences and really to determine if any of these scores could be applicable and appropriate for use with COVID-19. So the researchers actually looked at two primary indicators, measures. They looked at the prediction of the risk of death, and they wanted to be able to evaluate the feasibility of improving medical management decisions by adopting relevant scores into clinical practice. And they did that by looking at 654 patients who were enrolled. Of those 654 patients, there were 133 non-survivors. So these scores were actually completed on admission. And with the ADROP score, the initial intent of this tool was to assess the clinical severity of community-acquired pneumonia. The key question was, could this tool, intended for the assessment of severity of community-acquired pneumonia, be adapted for use with COVID-19? So there are a number of categories and indicators, and we'll walk through those in just a moment. But there was a 1-point score for each category, and a 1-point score increase is associated with a higher risk of in-hospital mortality with an odds ratio of 3.8. In this study, the superior performance of ADROP is likely due to the more accurate assessment of respiratory function because it includes SpO2, it has the ability to incorporate PO2 from an arterial blood gas, and it looks at respiratory rate measurement as well. It also incorporated age differentiation, and specifically it had a cutoff of greater than 70 years for males, greater than 75 years for females, and that likely contributed to some of the increased accuracy over the other scoring algorithms. While the Pneumonia Severity Index was created really to look at risks associated with community-acquired pneumonia, the algorithm doesn't have any of the respiratory function observations incorporated into it. And so for that reason, it simply did not have the sensitivity to be a reliable tool for the assessment of COVID-19. If we look at the News2 algorithm, we find that while it does incorporate indicators for the use of supplemental oxygen, there's not enough depth in that to really reflect the severity of hypoxemia, and for that reason, the News2 algorithm did not perform nearly as well as the ADROP algorithm did. The other element that's really important to consider is that when we look at these algorithms, the ability to incorporate not only respiratory function data, but also end organ data, especially in the form of a BUN, looking at renal perfusion, also adds additional information that's extremely useful, very, very valuable in observing and assessing in predicting the likelihood of clinical changes in COVID-19. And as you can see on this table, the sensitivity and specificity found in ADROP was significantly superior to the other tools that were used. And I think we'll be seeing more work done to really expand a deeper understanding of ADROP with a broader population. And again, this is a comparison of the operator curves and the accuracy. And as you can see, the ADROP, the expanded ADROP, had very, very good sensitivity and specificity. One other study that actually focuses on looking at the COVID-19 population on admission and initial presentation at the emergency department was actually done looking at these specific patients. And the study was undertaken to assess and compare the performance of MEWS2 and other commonly used clinical risk scores. These patients had a median age of about 67 years. 23% of the patients that presented actually had severe disease. And the in-hospital mortality rate was around 20%, slightly above what we had seen and had reported from sites around the U.S. and other parts of the world. 42% of the patients who presented on admission had a MEWS2 score of greater than 5. 30% actually had a score of greater than 6. Unfortunately, cutoff scores of 5 and 6 were used for MEWS2. The QSOFA scores were cut off at 2 SIRS, and also Group 65 also used a cutoff of 2. And this sample size being very small and the cutoff scores is the primary concern from all of this is that the MEWS2 does not afford the means of documenting the details, again, of respiratory support. And so it made it very, very difficult, given one snapshot, to really provide the prediction of deterioration. The sensitivity and specificity for both of these algorithms is there, and as we can see, the MEWS2 greater than or equal to 5 has a sensitivity of 86.7. There was a little bit of improvement in specificity with MEWS2 scores greater than or equal to 6. So I want to advance now to looking at the top variables predicting ICU admission. This is work that was actually done at Stony Brook University, and as you recall, the greater New York area was heavily impacted by COVID-19 back when the pandemic first manifested itself here in the United States. And so the team there recognized the urgent need for an effective triage tool. They needed a triage tool to assist frontline clinicians that were in the midst of managing the COVID-19 pandemic. The potential for rapid deterioration is a very, very real concern. We spoke earlier in the presentation about patients who can present, they have minimal evidence of acute illness, and those patients, because of the severity of their hypoxemia, pose the greatest risk in terms of an untoward outcome. And so the primary outcome measures for this study looked at the admission to the ICU. So in other words, those patients who were initially evaluated, did they actually get admitted to the ICU, or did they in fact die? So the admission criteria for the ICU in this study included respiratory failure requiring mechanical ventilation, or patients who actually had another organ failure requiring monitoring in the setting of the ICU. There were 641 hospitalized patients that were enrolled during this time. 398 of those patients did not have critical illness and were actually admitted to a non-critical floor. 195 of the patients, after initial assessment, were admitted to the ICU. 82 died, and then 34 died after admission to the ICU. So there's a good distribution of population. The median age for ICU admission in this study was 60 years. Those patients that actually were transitioned to general care instead of the ICU, interestingly, had a mean age of 58. There was slightly higher incidence of bilateral pulmonary involvement as evidenced by chest x-rays on the patients moved to the ICU. 89% of those patients had bilateral involvement. 78% of the patients that were transitioned to general care actually had bilateral findings on their chest x-rays. The findings that are of particular note, heart rates of greater than 100, respiratory rates of 23 or greater, and SpO2s of 93% were significantly associated with ICU admission. And if we look back at the World Health Organization recommendation, 93% for an SpO2 is an indication for the potential need to move those patients, depending on the level of support that they're already receiving. So this particular table looks at the top 5 variables predicting ICU admission and the top 5 variables predicting mortality. And the team at Stony Brook created a risk score, and they used that score to predict ICU admission and mortality specific to COVID-19. The ICU admission risk score ranges from 0 to 5, 0 being the lowest risk, the lowest risk to highest risk. And then the risk factors for predicting mortality range from 0 to 7, lowest to highest risk. So the common top predictors of ICU admission and mortality are an elevated LDH, which is indicating cell death and injury associated with poor host immune response, higher susceptibility to severe viral infections. Procalcitonin levels also were an indicator of critical illness due to an infectious etiology. So as you can see, it's there as one of the top predictors as well. We've talked extensively now about reduced SpO2, and then lymphopenia. Another common characteristic of infection caused by cytokine-induced reactions in the body. So if we look at the risk stratification scores, we see there on the top the risk scores associated with ICU versus non-critical illness. And we also see the risks associated with mortality. So these findings are significant and very, very helpful in surveillance for the COVID-19 population. One additional study that I want to quickly walk through is the READY trial, and this study actually focused on predicting respiratory decompensation in COVID-19 patients through the use of machine learning. And the researchers conducted a prospective multi-center trial, and they evaluated the performance of a machine learning algorithm for the prediction of invasive mechanical ventilation within 24 hours of an initial encounter. They were able to enroll 197 patients in their study. 10 patients were placed on invasive ventilation within the first 24 hours. And the comparative tool was the modified early warning score, a bit similar to the national early warning score. And The diagnostic odds ratio for the machine learning algorithm was actually 12.58. And as you can see, there was a very, very strong sensitivity and a good specificity with this particular tool. They actually looked at 12 variables. And the nice thing about this particular study is that they looked at routine vital signs, in other words, information that's gathered routinely on patients every 4 hours. And then they incorporated commonly acquired laboratory test data. So diastolic blood pressure, systolic blood pressure, heart rate, temp, respiratory rate, SpO2, white blood cells, a platelet count, lactate level, BUN, creatinine, bilirubin. And so what they found was that by getting this measurement of data points done within the first 2 hours after arrival in the ED, they were able to provide a means for admitting the patient to the appropriate clinical setting based upon the likelihood or probability that the patient was going to require intubation. So from a bed management standpoint, from a staff resource management standpoint, this tool created an opportunity to send those patients to the ICU if in all probability they were going to deteriorate. And this is extremely important when we think about the potential, the probability of needing to do an emergent intubation. There's extensive work that's been done looking at the risks of brain impairment, neurologic impairment, or even death when we're doing emergent intubations outside the setting of the operating room. And so one of the opportunities then through this study is to be able to identify those patients that are in all probability going to need to be intubated, and to be able to do that with the highest level of safety that's possible, hopefully avoiding the emergent intubation that, as the patient shows clear evidence of deterioration. So to summarize, when we're looking at patients outside of the ICU, as I mentioned, monitoring these patients is extremely important. But incorporating the use of assessment tools and algorithms, machine learning, we've talked a little bit about a couple of algorithms today that show great promise. But ultimately, the focus needs to be on the blending of both current monitoring, patient monitoring that's available today in the form of oximetry, respiratory rate monitoring, and then combining that with physical assessment as all care begins with the patient. When we look at the escalation of care, we have low flow, high flow oxygen delivery. The high flow cannula practice in most facilities that I'm supporting use the 40-40 rule of 40 liters a minute, 40%, as an indication of needing to go ahead and make preparations for using non-invasive support. So the American Society of Anesthesiology looked at the need for intubation, the call for intubation, and this particular diagram flowchart actually, again, focuses on respiratory rates in excess of 30 breaths a minute, or a PF ratio of less than 300 as indicators for the need for intubation. So to summarize, many COVID-19 patients do not require critical care, but it's extremely important and will be very, very beneficial for scoring systems, including artificial intelligence and machine learning, to be able to support the standardization of patients that are likely to require escalation, so that those patients can be admitted, transferred, relocated to an environment that affords them an opportunity for proactive intubation versus emergent. And as you've seen, a number of these studies have very, very small sample sizes, and so a large randomized control trial really would be the best way to confirm the best severity score. So I want to thank you for your attention and your time today. This concludes my presentation. And before we begin questions and answers, I would like to turn the presentation over to Kathleen, and she'll tell everyone how you can obtain your CEs for this session.
Thank you so much, Steve, for that real timely and thought-provoking presentation. I'd like to remind the audience on how to obtain their CEs for this activity. Again, this activity is approved for 1 contact hour. To obtain CE credits, go to, and it is important that you put the www in. So it's www.saxtesting.com/BO, and you're going to need to register to the site, complete the evaluation, and upon completion, you'll be able to print your certificate of completion. Remember, this education activity was supported by Philips. There will also be an archived version on demand that is going to be available at better-outcomes.org. An email will be sent to all registrants when it's available. The on-demand version will be accredited for nurses and respiratory therapists. Now, I'd like to start the Q&A. I know we only have a few minutes, so we've got a couple of questions. One, a question asked by Nick: is there widespread adoption of the MEWS-2 scoring system?
Very good question. So we find that the use of these algorithms involves a transformation of practice. And there is some adoption. The United Kingdom has embraced the MEWS-2 algorithm. Here in the United States, it's not nearly as commonly accepted. So there's still much work to be done in order to do the validation necessary to see widespread adoption specific for COVID-19.
Thanks. So John asked, before COVID-19, what was MEWS-2 scoring system originally used for?
So the original purpose of the MEWS and ultimately the MEWS-2 algorithm was to create a standardized assessment, evaluation, and deterioration tool that could be applied at facilities throughout the United Kingdom in an effort to improve communication and collaboration, whether it was physician to physician, nurse to nurse. And then in those situations where patients needed to be moved from an outlying facility to a tertiary center, there was history there that could be used to understand and appreciate the severity of illness.
So Gordon asked, did the predictive ability of MEWS-2 through variability of score find that it was a total MEWS-2 score or variability in particular scores like respiratory rate, saturation, so on?
A very good question. And actually the variability that they looked at and appreciated was actually the overall amount of variability. So they found that if that score increased by 5, during the course of that assessment period, that had the highest predictive value.
Awesome. Doris asks, what is the easiest algorithm to use in real-life situations? That's a great question.
That is. It's a very, very good question. And there is a lot of debate. Even in the research that's available today, if you go online, you're going to find that there's a lot of debate. My response to that is, anytime we rely on an algorithm, we're having to transform practice, and therein lies really the biggest problem. It's getting the adoption and having it universally accepted by the extended care team. So that doesn't really answer your question, but I'd be happy to connect with you offline if that would be helpful to talk in more detail.
Awesome. And one last question before I turn it back to Monica. Do you think vital sign taking should be returned back to the registered nurse for greater accuracy?
Well, I have the privilege of working with hospitals across the U.S., and I have found and really been blessed by the opportunity to work with a number of both nurses and nurse techs, and there are some very, very skilled nurse techs. I do have concerns that given the subtle signs, especially with neuroassessment, early onset confusion, that there are many times where I believe that vital signs performed by registered nurses would likely have identified deterioration earlier. But there are a number of very, very strong nurse techs out there today.
So that concludes our Q&A. And so I would like to turn the presentation back over to Monica for concluding remarks.
Thank you. Thank you so much. This does conclude our webinar for today, and I'd like to remind the audience that there is a survey for you at the conclusion that will pop up immediately, and we greatly appreciate you sharing your opinion on today's webinar. We certainly appreciate your feedback. Thank you again. And on behalf of our presenters, Sachs Healthcare Communications, and our sponsor, Philips, I hope you enjoy the rest of the day.